Assalamu alaikum. This is Dr. Amna. Previously, I have uploaded the um, management of ovarian cyst in the premenopausal and postmenopausal women. So now there's few important topics regarding ovarian cyst, uh, which are included in exam part 2 and part 3 exam, because they can ask what type of benign cyst, ovarian cyst are present, and what types of malignant ovarian cyst, and what are the characteristic features, and how you will you can identify that this cyst, ovarian cyst, which you have seen on ultrasound, keeping in mind the age group of the patient and the symptom regarding cyst. So, what is the most likely cause of this ovarian cyst? Which type of this ovarian cyst? So, this presentation is about benign ovarian cyst, and I will upload another presentation regarding malignant ovarian cyst. I have divided in parts so that it will be easy to digest. And I will also upload another video regarding genetic component in the ovarian cyst, because that point is also very important in the part 2 and part 3. They will include the genetic component of the ovarian cyst, the ovarian malignancy, because it runs in the family and there is increased risk of cancers in the BRCA carriers, BRCA1, BRCA2, and the Lynch syndrome. So this presentation is regarding benign ovarian cyst and what are its type. So benign disease of the ovary, ovarian cyst identified during gynecological investigation, for example, for postmenopausal bleeding, because I have mentioned in the ovarian cyst in the premenopausal and postmenopausal women, because these cysts generally does not cause any specific symptoms. They can be identified because of some gynecological investigation due to some other cause, like postmenopausal bleeding, or they can be identified in some non-gynecological investigation, like investigation for appendicitis, pancreatitis, or they can present as ovarian torsion or rupture. So one way is this, and second is some ovarian cysts are found incidentally in the postmenopausal woman undergoing investigation by other specialties. For non-gynecological conditions, for example, cross-sectional imaging for general surgeon, or medical indications. The differential diagnosis of pelvic mass include tumor of adjacent structure. If you see a pelvic mass, it's given in the exam, we can think about the gynecological and the non-gynecological factors as well. In the gynecological factors, we can see that we can assume that this pelvic mass can be from uterus, from bladder, bowel, and it can be because of pregnancy. So whenever there's a pelvic mass, we will have some differential diagnosis in our mind. This differential diagnosis is important as, for example, in the structure discussion part 3, they can ask you to give them the differential diagnosis of the pelvic mass, or even in the simulated patient task, you can give the differential to the patient. There can be a pelvic mass due to gynecological indications, gynecological conditions like benign and malignant ovarian cyst, torsion, para-ovarian cyst, ectopic pregnancy, hydrosalpinx, pyosalpinx, tubo-ovarian abscess, tubal malignancy, pregnancy, fibroid, and uterine malignancy. There are gastrointestinal causes, small or large bowel obstruction, diverticular, appendicular abscess, intussusception, and malignancy. Regarding urological conditions, hydronephrosis, pelvic kidney, renal bladder malignancy. And others include pelvic lymphocele, peritoneal cyst, psoas muscle abscess, lymphoma, neuroblastoma, and aortic aneurysm. Diagnosis of ovarian cyst is made on TVS. This point we know very well in the premenopausal and postmenopausal women. Diagnosis is only on the TVS. CT scan is only indicated when you suspect that this cyst is malignant. So before referring to the multidisciplinary team, you will arrange a CT scan. And MRI is only indicated for ovarian cyst when TVS is inconclusive. You are unable to differentiate between benign or malignant. These points I repeated in every presentation because these are exam points and they ask about it again and again. So for remembering and for dividing easily the ovarian cyst, as we know that in the ovary, there are three mainly important structures like germ cell, from where eggs are formed. So if the cell, there is any cyst or benign or malignant arise from germ cell, we call it germ cell tumors or germ cells, cyst arises from that. And there can be stroma, ovarian stroma, which includes granulosa theca cells. So these stroma is very important for hormone protection on the granulosa cells. FSH act and produce estrogen. And on theca cells, LH act on theca cells. So if there is any and also there are fibroblasts. These three structures are in the stroma. So if there's a granulosa cell tumor or theca cyst or fibromas, these arise from the sex cord stromal. These are sex cord stromal tumor. And then comes the surface epithelium. Surface epithelium does not have any specific function, correct role in the functioning of the ovaries, just the covering of the ovary. But it's very important because majority of majority of the ovarian tumors are epithelial, and they arises from this surface epithelium. First, I will. This is for the. I try to make it as easy as we can. So the benign ovarian cyst can be functional because they comes and goes, and because of these cysts, because there a lot of there increased incidence of functional cyst, and for these cysts we need to if it's a small size, we will especially in the premenopausal group up to 5 centimeter, up to 5 centimeter. We do not have, if this is simple cyst, and we less than 5, actually it is less than 5 centimeter, there is a simple cyst in the premenopausal woman, we even do not need to do the follow-up scan. In the if the cyst simple cyst is 5 to 7, then we can repeat the scan, yearly scan, because these functional cysts will resolve in 2 to 3 cycles. So functional cysts include follicular cyst, corpus luteal cyst, and theca luteal cyst. Follicular cysts are basically the when there's a growth of the ovum, and it should be released at the time of ovulation. But if it does not release the egg, or it punctured and then reseal and egg is not released, so it grows, follicular cyst grows in size. So this is called as follicular cyst. It will resolve in 2 to 3 cycle. And corpus luteal cyst and is when the ovary, when there's ovulation and the follicular cyst release egg, then this turn into the corpus luteum. And corpus luteum, if there is no pregnancy, the corpus luteum generally degenerates. But if it does not degenerate, it can turn into the cyst. But it can also resolve with 2 to 3 cycles. All the functional cysts can resolve in 2 to 3 cycles. Then comes the inflammatory. It's the tubo-ovarian abscess, endometriomas, tubo-ovarian abscess, and tubo-ovarian abscess and endometriomas. Tubo-ovarian abscess due to pelvic inflammatory disease. So its management and diagnosis is according to symptoms. We will explore. We can differentiate from the symptoms of the patient, because she must be in the high risk group for sexual transmitting infections, or she must be having some points in the history, like new relationship, or using copper coil, because incidence of pelvic inflammatory disease is more if the copper coil is placed within 3 months. And this endometrioma is associated with the history of the endometriosis in the patient. Then comes other cyst, which I have divided according to ovarian structures: germ cell, epithelial, and sex cord stromal tumor. In the germ cells, there are benign teratoma. There's a dermoid cyst. As we know that from germ cells, eggs are produced, and from eggs, all the all the layers of the epidermis, mesoderm, and endoderm are produced. So in this cell, there can be any type of structure can be there in the dermoid cyst. But generally, there are skin appendages, hair, and also there is a there can be teeth, which can be easily seen on ultrasound, and there can be because it contains the skin glands and tissue, so there can be sebaceous cyst. Sebum will be there. So I will describe it in detail in the next slides. So epithelial increase serous cyst adenoma, mucinous cyst adenoma. and the Brenner tumors. The sex cord stromal tumor involves fibroma and thecoma. And now I will tell about the small detail about these cysts. So how can we, if comes in the exam, they give some feature regarding the cyst and they want to know what type of cyst is this, because they can give this scenario in the part 2 exam. So whenever there is a young girl, they give the young girl age of 18, 19, and there's a cyst and simple cyst. And basically this cyst is common in young girls, adolescent, and women in their reproductive year. Diagnosis is made when the cyst measures more than 3 centimeter, because normal ovulatory follicle measures up to 2.5 centimeter. Rarely grow larger than 10 centimeter and appear as simple unilocular cyst on ultrasound. A repeat ultrasound performed to check resolution or non-enlargement. Then comes a corpus luteal cyst. Corpus occur following ovulation and may present with pain due to rupture or hemorrhage, typically late in menstrual cycle. So whenever a patient is having pain and she comes and you see it's a cyst, you can ask about the menstrual cycle, at which stage she is on the menstrual cycle. You can assess about the type of cyst. So treatment is expectant with analgesia. Occasionally, surgery may be necessary if there has been significant bleeding to wash out the pelvis and perform an ovarian cystectomy. Then the thecal luteal cyst associated with pregnancy, particularly multiple pregnancy and molar pregnancy, because whenever there's an increased beta hCG in the body, there is increased risk of thecal luteal cyst. These are often diagnosed incidentally or at routine ultrasound, and they are often bilateral. Most resolve spontaneously during pregnancy. Then comes the tubo-ovarian abscess. As I have mentioned that these associated with pelvic inflammatory disease, you can see from the history that what type of cyst can be there. Most common in young women, may involve the fallopian tube, ovary, and bowel. Can develop from other infective causes, for example, appendicitis or diverticular disease. Diagnosis is similar to that of pelvic inflammatory disease. Initial treatment is with antibiotic and supportive measures such as fluid rehydration and the antipyretic paracetamol. Surgical drainage or excision is required if there is a swinging pyrexia and you see that there's a clear sign of abscess, then you have to do the surgical drainage. Then comes the endometriomas. These are known as chocolate cyst due to the presence of altered blood within the ovary. These cysts have a ground glass appearance on ultrasound. Symptomatic endometriotic chocolate cyst should not just be drained, but the inner cyst lining should be excised or ablated to reduce the risk of recurrence. And after these cyst follicular, functional cyst and the inflammatory cyst, now we will come to the cyst according to structures in the ovaries, like germ cell and stromal, sex cord stromal cells, and then epithelial cells. So according to we start from germ cell tumors. These are the benign teratomas, dermoid cyst. Most common ovarian tumors in young women aged 20 to 40 years. So this is all, normally we say in the premenopausal group, there's a very low risk of cancer. But there can, generally there are simple cysts, but sometimes they can be complex cysts, but this is not, this is benign. Complex cyst in the young women can be benign because of increased incidence of benign teratomas. These occur in the women with between 20 to 40 years and a peak incidence in those in their early 20s. Mature dermoid cyst, cystic teratoma, which contains fully differentiated tissue types derived from all 3 embryonic germ cell layers: mesenchymal, epithelial, and stroma. Hair, teeth, fat, skin, muscle, cartilage, bone, and endocrine tissue are frequently present. 10% of dermoid cysts are bilateral. Mostly these are unilateral, but 10% are there which are bilateral. The risk of malignant transformation is rare, less than 2%, usually in women above 40 years. Ovarian cystectomy is indicated because spontaneous resolution is unlikely, and surgery is indicated when, if the dermoid cyst is symptomatic and if more than 5 centimeter in diameter or is enlarging. Cystectomy will prevent ovarian torsion and provide tissue for the histological analysis. So this is all about benign teratoma, because they can take question from this slide. This can be like what can be present in the derma. They can give the scenario which hair, teeth, fat are present, age group has been given, and this is symptomatic, and it's increasing in size or not. So then patient is woman is having problem, then you can do the surgical removal of this. In the epithelial tumors, we have serous, mucinous, and Brenner tumors. Serous cyst adenoma, these are all benign because these are cyst adenomas. When there is malignant, we will say adenocarcinoma. So then comes the most common in serous cyst adenoma, most common in perimenopausal women. The most common epithelial tumor, accounting for 20 to 30% of benign tumors in women under 40 years of age. Typically unilocular and unilateral. Then comes the mucinous cyst adenoma. These are large multiloculated cysts. Bilateral in 10% of cases. As in the guidelines I have mentioned, specifically they have mentioned again and again that in the ultrasound, there is no single finding in the ultrasound can differentiate between benign and malignant. So you can see in the benign tumors, there are also multilocular cysts. There are also complex cysts which can have solid structure, but these are benign. So we cannot differentiate. We need to see the age of the patient, the family history of the patient, the characteristics of cyst, and is it increasing or it's causing symptom, and also about the tumor markers, and if risk malignancy index can be calculated, and iota classification will be seen, and then we will decide about whether this is benign cyst or malignant cyst. In the Brenner tumor, often found incidentally within the ovary, contains urothelial-like epithelium and may rarely secrete estrogen. Here come sex cord stromal tumors. So these are basically tumors which are hormone-producing tumors. But hormone-producing tumors are only thecomas and thecomas, because fibromas are from ovarian fibroblasts. So as fibroblast does not produce any hormone, so there will not be any tumor marker in the even in the malignant. Even malignant, there is no increase in the hormone level. So obviously, it's not a tumor marker in the benign condition. Tumor markers term is used for the malignant cases. Here, I'm just telling that these are hormone-producing growth, and ovarian fibroma does not produce any hormone. So ovarian fibroma, most common sex cord stromal tumors. Solid ovarian tumors composed of stromal cells. So this is the main risk factor. This does not produce hormone, but still they are solid. For problem with the solid ovarian tumors are that they can have torsion, and they can cause symptoms. Present in older women, often with torsion due to heaviness. Patient may present with Meigs syndrome. Fibromas are associated with ascites. Again, here comes the point that no single ultrasound finding can differentiate between malignant and benign growth, because ascites are generally considered as that it should be there in the malignant case. But ovarian fibromas are benign condition, but still they are associated with the ascites. And when patient there's also Meigs syndrome. In the Meigs syndrome, there are also pleural effusion. Whenever you see pleural effusion, ascites, and ovarian fibroma, then it's a this picture is called Meigs syndrome. So following removal of the ovarian fibroma, the pleural effusion will usually resolve. Then comes thecoma. These are benign estrogen-secreting tumors, often present after the menopause with the manifestation of excess estrogen production, usually postmenopausal bleeding. Although benign, they may induce an endometrial carcinoma. As we know, whenever there is an excess of estrogen production, the more endometrial growth will be there, and there will be endometrial hyperplasia, which in turn lead to endometrial carcinoma. So because whenever in a normal menstrual cycle, when estrogen come and the endometrial lining grows in size, and then progesterone come, and then the shedding of the endometrium is there. But here there is no shedding, and endometrium is continuing in size in the growth, and ultimately it will turn into a hyperplasia and then endometrial carcinoma. Thank you. This is all about ovarian benign cyst. So I will upload the next presentation about the malignant ovarian cyst. Thank you so much.